Hey guys, this is Dr. Sclafani. I'm one of the online lab faculty for University of St. Augustine in this imaging course, and I'm also a sports PT. And I'm going to be talking to you guys today a little bit about some elbow imaging and how it applies to a sports population. So some of the things that we're going to be talking about today include a review of some of the x-rays, as well as a couple different pathologies that you're likely to see in your outpatient sports medicine population. So as we start to examine x-rays of the elbow, be sure to identify the ulna and the radius so that you can stay oriented to medial versus lateral sides of the elbow. That'll help you as you look at different images. So a typical view of the x-ray includes an AP view and a lateral view when we look at the elbow joint. So some of the important structures to identify on an AP elbow x-ray include the radial head, the capitellum, the olecranon process, the trochlea, and the coronoid process. So we're going to be discussing certain pathologies later on that will be unique to the medial versus lateral aspect of the elbow. So just keep track of your orientation to laterality. When we look at someone's elbow, even without an x-ray, we want to see a little bit of what's called a carrying angle. This is simply the angle that the forearm makes in relation to the humerus. Notice that the normal carrying angle is in slight valgus to prevent the hand from hitting the outside of the hip during normal walking. So when assessing the carrying angle, the elbow must be in full extension and supination. On an AP X-ray, the carrying angle is measured by drawing a line along the humeral shaft and then the midline of the ulnar shaft. This angle can be measured below the joint line, as is pictured here in yellow, or directly across the joint line that would be straight across in a diagonal fashion from where the angle is drawn in this slide. You may see angle measurements taken either way. So let's change gears to a lateral view of the elbow. So typically lateral x-rays of the elbow are taken at 90 degrees of flexion, and they'll be from the radial side. We'll highlight a few alignments as we progress through the elbow unit today. So one thing to investigate when you first look at a lateral elbow x-ray is that the radial head is aligned with the capitellum. Another thing to look at is the congruency of the ulna with the trochlea. Examining the alignment of both of these pairs of structures is a great place to start when looking at a lateral elbow x-ray. Other structures that are helpful to examine on a lateral elbow x-ray include the radial or biceps tuberosity and the anterior fat pad. So we'll talk later in more detail about the anterior fat pad and some of its implications on a lateral x-ray. So there are two radiographic lines that we're going to investigate further to help us analyze a lateral elbow x-ray. The first one is the anterior humeral line. It's a line drawn along the anterior surface of the humeral cortex in a vertical direction. It should normally pass through the middle third of the capitellum. If this line passes anteriorly through the anterior third of the capitellum, it suggests a supracondylar fracture and posterior displacement of the capitellum. On this image, lines are already drawn on the capitellum to divide it into thirds. Here you can see how the anterior humeral line intersects with the anterior third of the capitellum. You can then clearly see the posteriorly displaced fragment as well. The other thing that we're going to look at is the radiocapitellar line. So the radiocapitellar line is a horizontal line drawn along the radial neck. It should normally pass through the center of the capitellum. One word of caution, though, when evaluating the radiocapitellar line is to avoid using the radial shaft as the start of this line. So the radius is slightly angulated at the neck, and so that angulation can actually skew the alignment of this line if you use the shaft as opposed to the neck. When the radiocapitellar line does not intersect the center of the capitellum, it is typically the result of a radial head dislocation. So this dislocation or malalignment can either be in isolation or it can be a sequela of a fracture. So the image on the left shows a radial head dislocation that occurred in a younger patient with open growth plates. Isolated radial head dislocations are more common in this demographic, in that younger population with open growth. So here you can see a proximal ulnar fracture that resulted in a radial head dislocation and a subsequent abnormal radiocapitellar line that intersects too far superiorly on the humerus way above the capitellum. So let's change gears now to talk more about the anterior fat pad that we mentioned earlier. In a normal lateral x-ray of the elbow, the fat pad is a darker silhouette that sort of hugs the anterior cortex of the humerus, as we can see in this arrow. So in the presence of any elbow joint effusion, the anterior fat pad will elevate, similar to the billowing of a sail, as you can see on the right-hand picture. So in this lateral x-ray, a minimally displaced radial head fracture results in some of that elbow of joint effusion, which then produces a billowing appearance of the anterior fat pad. The elbow section on Blackboard does a really nice job of going through fracture assessment and classification specifically for the elbow, so definitely check that out as well. So now let's look at some of the soft tissue injuries that can occur and their implications on imaging of the elbow. The first soft tissue pathology I want to discuss is lateral epicondylalgia. So this is commonly referred to as tennis elbow or lateral epicondylitis, but the itis suffix is often a misnomer and it should really be referred to as lateral epicondylosis. An easy way to differentiate the lateral versus medial elbow on an AP X-ray is to look at the radial head. With the forearm in a supinated position, remember that the radius is on the lateral side. Just superior to the radius is the capitellum and then the lateral epicondyle. With lateral epicondylalgia, an X-ray is typically benign and is oftentimes used to rule out other potential pathologies, such as a fracture, osteoarthritis, OC lesions of the capitellum, which we'll discuss later. However, in this particular series of X-rays, we can see some of that calcification that has occurred just off of the lateral epicondyle into the soft tissue along that common extensor tendon. So this is a T1 weighted MRI of the lateral epicondyle. This is how the lateral epicondyle and the common extensor tendon should normally look. Make sure to look at the cortex of the lateral epicondyle and the enthesis of the common extensor tendon. Both should have a low signal intensity that is demonstrated by the yellow arrow in both of these MRIs. These are MRIs of a patient with lateral epicondylalgia. Note how on both the T1 and T2 weighted MRI images, there's clear thickening of the cortex of the lateral epicondyle. Remember, we're looking for cortical disruption right at the very lateral edge of the lateral epicondyle. There may or may not be any inflammation in some of those more chronic tendinosis type cases, so don't be alarmed if you don't see that typical white signal that is oftentimes seen as inflammation in more of that T2 weighted image. So this is an image of a 46-year-old tennis player with chronic lateral elbow pain and a clinical diagnosis of lateral epicondylalgia. So this T2 weighted MRI shows thickening and that high signal intensity within the common extensor tendon origin, and that's indicated by the smaller arrow. The larger arrow shows the lateral collateral ligament, which is intact but is actually thickened and irregular. So this is a musculoskeletal ultrasound of the lateral epicondyle. So musculoskeletal ultrasound is gaining a lot of popularity, and some PTs are beginning to utilize this imaging modality, not just for research purposes, but also in the clinic. So this particular image shows a healthy male volunteer in the absence of any lateral elbow pathology. So the transducer, or the sound head of the ultrasound, is oriented in a longitudinal fashion in this image so that it's parallel to the forearm. This longitudinal sonogram shows a normal common extensor origin, which is indicated by the arrow. And you can tell that it's normal because it has a uniform band of tendon fibers that are running closely in parallel towards the lateral epicondyle, which is indicated by the asterisk. Now let's take a look at an abnormal musculoskeletal ultrasound. So this is a 35-year-old male tennis player who presented with left elbow pain. So on this longitudinal sonogram, it reveals linear fissures extending obliquely through the tendon, which is indicated by the small arrows, from the deep surface, and is characteristic of that partial tearing at the common extensor origin, which is indicated by the larger arrow. So now let's transition to the medial side of the elbow. Similar to lateral epicondylosis, medial epicondylalgia is typically caused by tendinopathy of the forearm flexors. So this is the same normal AP elbow X-ray with the lateral epicondyle highlighted. Just as in lateral epicondylalgia, X-rays will oftentimes be benign for this condition. However, in this particular AP X-ray, there is visible soft tissue calcification about the medial epicondyle. So these images are both T1 weighted images. Both of these show the normal aspect of the medial epicondyle, which should have a low signal intensity, as you can see by the red arrow. Look at how much cortical disruption has occurred at the medial epicondyle in both of these images. In the T1 image on the left, that dark black spot in the center of the medial epicondyle demonstrates that cortical disruption has occurred. Along the common flexor tendon, there really isn't too much involvement. However, on the T2 image on the right, the medial epicondyle appears very bright, as does the signal along the common flexor tendon. So that's the bright signal along that tendon that indicates that there is partial tearing of the common flexor tendon with a little bit of that inflammation as well. So here are two more MRIs investigating pathology around the medial epicondyle. So these T2 weighted images show partial tearing of the common flexor tendon. In the image on the left, you can visualize the area of the partial tear along the white line, as well as the resultant surrounding edema that is also white on a T2 weighted MRI. Now look at the image on the right, which is a sagittal view. Although the tear appears small when the image is zoomed in like this, it's actually pretty painful for the patients. So it's going to be important, and just like all the other imaging modalities that we've talked about in this class, you're only as good as one view. So you need to be able to look at different views, and the elbow is no different. So this is what a normal musculoskeletal ultrasound looks like in this particular area. So note the continuity of the fibers of the common flexor tendon and the smooth edges of the medial epicondyle. Now let's take a look at an abnormal musculoskeletal ultrasound of this area. So this is a longitudinal ultrasound again of the medial epicondyle and the common flexor tendon. So note the area of hypoechogenicity, which is that black hole just distal to the medial epicondyle along the common flexor tendon, which is indicative of that tendinotic condition. So that's why a lot of times we should refer to these as medial epicondylosis and not medial epicondylitis. So here are two more abnormal musculoskeletal ultrasounds of the medial epicondyle. Image A is taken along the same longitudinal plane, while image B is along the transverse plane. So just like we talked about earlier, as with any imaging modality, you have to look at least two planes in order to get a complete three-dimensional picture. So we can see a calcification within the flexor pronator mass as well as that hypoechogenicity around this calcification. Because we have images in both planes, we're able to exactly locate the lesion within the anterior aspect of the tendon. And we wouldn't be able to do that without B, which is that transverse plane image. So let's change gears now to that main ligament of the medial side of the elbow, which is the UCL. So one way that I like to segregate the UCL and the common flexor tendon clinically is to draw an equator that divides the superior and the inferior aspects of the medial epicondyle. And what this will do is just north of that equator is the common flexor tendon, and just south of that equator lies the UCL. So this is just a review of some throwing mechanics and the valgus stresses that typically we see with UCL sprains or UCL injuries. So don't forget that there are actually three bands or bundles to the UCL. The anterior bundle receives the most attention, which we'll see soon as we look at imaging for this particular structure. So the anterior bundle of the UCL in the elbow is most easily seen in the coronal plane, as in this particular T1 weighted image. Depending upon slice thickness, it is usually visible on 2 to 3 consecutive coronal slices. It is normally of low signal intensity on both the T1 and the T2 weighted images. Look at the relatively increased signal intensity within the proximal attachment, which lies along the undersurface of the medial epicondyle. The white arrowheads point to the common flexor tendon fibers, which lie in close proximity to the UCL, but they also lie medial to the UCL and attach more superiorly along the medial surface of the medial epicondyle. So in this particular picture, this is a normal T2 weighted MRI. And note the increased signal intensity along the proximal aspect of the UCL, and that's considered normal for this particular area. So this may help visualize the path of the UCL a little better. This is a T1 weighted MRI of an 18-year-old professional baseball pitcher. The blue arrows help to trace the UCL, which has been thickened, and that's likely due to repetitive stress during pitching. However, there is no focal abnormality that might indicate a tear of the UCL. So we can just simply follow the blue arrows down, and we can kind of trace out that UCL now that it's been thickened and a little bit easier to see all in one slice. So this is an axial image of the elbow, which can be very useful for visualizing the UCL in more of an anterior-posterior direction, since you'll get more of a top-down view of the ligament itself. So a partial tear of the UCL can be hard to visualize sometimes. So this is an 18-year-old baseball player that underwent this T2 weighted MR arthrogram. And those partial tears can sometimes be helpful to look at under an MR arthrogram. So when we have a partial tear of the UCL, it usually results in some inflammation, which will appear bright on a T2 weighted image, especially with an MR arthrogram. So as the dye travels medially, a T sign may be seen, which indicates that partial tearing of the UCL. We can see that T sign a little bit more clearly on the right. So this is an MRI of a complete rupture of the distal portion of the UCL, and is most easily visualized due to the detachment from the sublime tubercle and then the resultant edema around the sublime tubercle from the UCL rupture. We can see that a little bit more clearly in the image on the right, a little bit more of that edema right there. So this is a coronal T2 image of another professional baseball player. On the left image, the yellow arrow points to the anterior bundle of the UCL, which is intact as it firmly attaches to that sublime tubercle. As we scroll through the MRI study, which will progress posteriorly through the elbow, the red arrows point to edema and some of that soft tissue edema that gets more intense as we scroll through posteriorly again. This cues the clinician into a posterior bundle injury of the UCL, and that would have to be correlated a little bit clinically as well. So we change gears again to the axial view of this same patient. Look at the red arrow. So this particular view confirms from what we saw in the coronal view that the anterior bundle is in fact intact. However, the yellow arrow again points to the posterior bundle, which we can see is clearly disrupted. So this would be read as a partial tear of the UCL. Clinically, this patient most likely would not be a surgical candidate, but if they're an athlete, they may be restrained and pulled from their particular sport for a period of time to allow healing to occur a little bit more along that UCL ligament. So let's change gears again. So one thing that's very common in the sports population is an OC lesion of the capitellum. So we've started to kind of change a little bit in our medical terminology to shift away from an OCD lesion, which stands for osteochondral dissecans, and we've kind of changed from OCD lesions to OC lesions. So leaving the osteochondral part in, but then removing the dissecans or sort of that defect. So the defect terminology is no longer necessary. It's just been a little bit more prudent to refer to these particular pathologies as lesions. So you may start to see a shift in some of the literature, but of course in some of the older literature you're still going to see OCD lesions or osteochondral dissecans described. So this is a nice drawing of where the OC lesion occurs on the capitellum. So I oftentimes describe this particular pathology to patients as kind of a small pothole that dips into not just the bone but also the cartilage as well. So as the elbow moves into flexion extension, plus or minus some of that regular valgus force or excessive valgus force from, say, pitching or contact or weight bearing in gymnastics, the elbow can actually kind of slide right into that pothole on that capitellum right there and cause a lot of pain, especially since you don't have that protective buffer anymore, and it's basically just colliding into that sensitive bone divot or defect and lesion. So here are normal AP elbow x-rays. So when we look again on both images, we can see the smooth edges of the capitellum and the radial head. So kind of take note of how wide the space is, how it's very clear, and there's nothing impeding that whatsoever. So here we can see that defect or that lesion of the capitellum that actually extends into the joint line. So we can see that little bit of that that chip that's now starting to go right into that joint space. So this particular radiograph is a 15-year-old baseball player with a 4-year history of elbow pain and just had a recent episode of locking. So notice how there is focal lucency actually in the capitellum and some fragmentation. So this is actually pretty typical for an OC lesion of the capitellum, and the locking is probably the result of loose bodies that have actually started to chip. So when we look at OC lesions of the capitellum, an MRI is typically used. They can occasionally be seen on an x-ray, as was in the last slide, but sometimes when this lesion occurs with the lesions of the capitellum, the impaction force that the elbow undergoes during pitching, contact, weight bearing in gymnastics, things like that, that particular force can actually knock loose a couple fragments of bone and cartilage and actually present as loose bodies floating around in the joint space. So these are actually MRI images of a normal elbow, and in particular a normal image of the capitellum and the radial head. So notice on both of them the smooth edges on both structures without the presence of any effusion, bone marrow edema, or any joint lesions that might be present. So now this is a series of images that were performed on a 20-year-old gymnast. So notice on the x-ray there is radiographic lucency of the capitellum. But if we change gears and look at the T2 arthrogram, we see some of that bone marrow edema right in the capitellum itself. Now all the way on the right, finishing with that T1 sagittal image of the elbow, there is subchondral bone abnormality, but there's really not that much of a lesion. So we can still see that black tracing of some of that subchondral bone abnormality that I mentioned, but it looks like it's actually a pretty stable fragment without any loose bodies. However, when we look at the joint itself, there's actually some cartilage thinning in there, but again, there is no lesion that actually dips into the joint line. So this gymnast probably underwent non-operative management that was probably utilized for several weeks just to allow everything to occur, and then she probably progressed back as her symptoms tolerated back to gymnastics. So here we can see an X-ray and an MRI correlation, and this is a 13-year-old male baseball pitcher. In the AP X-ray, there is a sclerotic outline of an OC lesion of the capitellum. So then if we change gears, looking at those same red arrowheads, we can easily identify that in the T1 MRI. So now in the T1 MRI, there's a clear osteochondral lesion. So due to the lack of the edema, though, that's surrounding this lesion, it can likely be deduced that this particular lesion, the OC lesion of the capitellum, is actually pretty stable. So what we'll do is we'll talk about unstable OC lesions on the next slide. So fluid that has completely encapsulated the OC lesion of the capitellum may be indicative of an unstable lesion. So look at how in each image there's a clear ring of fluid surrounding the lesion. So again, we can see in the red arrowheads, we can even see it all the way in the white arrowhead on the right. So one of the sports medicine orthopedic surgeons I used to work with would describe these unstable lesions as sort of like a crumb that is floating in syrup. So even though it might seem like it's staying put, the slightest shift or the wrong force in the wrong direction can actually cause it to kind of float away into the joint space and can result in some of the locking or some of the other mechanical pathology that we might see clinically or in sport. So therefore, these particular lesions are typically managed operatively. So that's all the material that I have for you guys. If you guys run into any questions or have any comments or concerns about anything that we talked about in this presentation, feel free to shoot me an email and I'll be happy to answer them for you.